Welcome everybody. Pleasure to be with you here all today. Today we're going to be going through our adherence accelerator, how AI turns access into outcomes. My name is Benjamin Rader. I'm the head of the pharmacy data team here at Inovalon. I have over a decade of experience working with clinical patient programs, shaping our clinical data strategy, and LDD program creation for our pharmacy partners. Here joined alongside Hayley today. Hayley, why don't you tell us a little bit about yourself?
Yeah, happy to. I'm Hayley Burgess. I'm the SVP of Provider Surveillance and Safety. I'm a pharmacist by training and spent the majority of my career in health system leadership, medication management, patient safety, infectious disease prevention, and started moving towards the technology sector and really passionate about workflow efficiencies and how you can take really robust data and assure that clinicians have what they need to make the right decisions, and fell in love with a software called Vigilance Pharmacy Surveillance. I implemented that in a large health system and then joined as their COO, and we were purchased by Inovalon about 2 years ago, and it's been a great transition for us, and happy to be here with Ben today. Thank you.
Yeah, so wanted to get us started here and just do a little thought exercise, right? So I just want you guys to imagine this scenario. A patient's diagnosed with Crohn's disease, right, and is prescribed a specialty medication that costs thousands of dollars per month. Now, this patient misses a dose either because of forgetfulness, side effects, or just even a cost concern, right? And a month later, they have a flare-up and they're hospitalized due to the disease's progression. The pharmacy wasn't aware, the provider wasn't alerted, and now the health plan faces a six-figure hospital bill. All of this could have been prevented if we had known sooner, right? So today we're going to be tackling one of the most persistent challenges in healthcare, and that's medication adherence. Throughout this presentation, we'll explore how automation, machine learning, clinical surveillance, natural language processing, and rule-based AI can revolutionize our ability to drive adherence, reduce hospitalizations, and enhance patient care. And so when we talk about access and outcomes, it's important to start with why adherence matters so much. So let's look at it by the numbers, right? Medication non-adherence is one of the biggest silent agents in healthcare. Every year, there's more than 3.8 billion prescriptions that are written in the United States, and yet only about half of those are taken as prescribed, right? That gap has enormous consequences, results in over $300 billion in what could be considered avoidable healthcare costs annually, and more important, worse patient outcomes, right? Maybe nothing worse than roughly 125,000 deaths in America each year just due to poor medication adherence. So these numbers tell a really powerful story, right? The medications work, but only when patients can access them, understand them, and stay on them, right? That's why we're so focused on turning access into outcomes here at Inovalon and using data, AI, and clinical insight to identify the right interventions at the right time.
I always like to talk data. So what does the data say about safety? And in the ambulatory space, Levine and colleagues published this paper about 2 years ago now, and their findings were that around 10% of patients on the ambulatory side experience adverse events. And where does that happen? Primarily in adverse drug events, around 64% of patients. And that's really terrifying. And if you think about your own experiences with your family, with yourself, of medications and how complicated these regimens can be. I remember my father-in-law has had congestive heart failure, and he was in the hospital for an exacerbation, comes home and has probably 15 bottles of meds. And I'm sitting at the table with him, you know, with the month, you know, or the week supply, like putting in the medications in each of its little morning, midday, evening, and how challenging that was. And I'm a pharmacist, and you think about individuals that don't have the expertise in their homes, and families are leaving with this disparate information, lack of communication going into the ambulatory setting, because they want to be at home, which is the right place, but it's where the majority of the care takes place. And I think this is such an important topic because adherence is, it's not even necessarily, I'm not going to take my med or I'm not going to take it exactly as it's prescribed, but in transitions of care, there are omissions where you don't have the right medication. Maybe it got discontinued and you didn't realize it. There are so many scenarios where this can break down. And one of my mentors, Dr. John Perlin, who's now the president of the Joint Commission, often says, we'll know we have arrived when patients can venture through healthcare without having to have an advocate at their side. And I think that's where Inovalon comes in with our technologies and our advancements, and especially as we're looking to AI and automation, some really interesting technology for fail-safes and safeguards for our patients.
And so when we kind of move it to just a specialty pharmacy lens for a second here, and we talk about the growth that we have here in the industry, specialty medications equate to roughly 2 to 3% of the prescription volume, but they account for more than 50% of the US drug spending, right? And we can see market forecasts are showing that's only going to increase further as we see the drug pipeline for specialty meds on a pretty steady trajectory, right? And for specialty medications, non-adherence isn't just a clinical strategy, it's a business challenge, right? You have lost revenue from abandoned therapies, inefficiencies from reactive interventions versus proactive, right? We're required to monitor and then take action after the fact. And then you also have that risk of non-compliance in value-based care models. So we're really stuck reacting and only realizing it after a patient has missed a dose or a refill's overdue. So the question I think really becomes, what if we're able to predict non-adherence before it happens and then proactively intervene on that? And so just to kind of break it down into 4 key areas that I would say are affected here by medication non-adherence. Non-adherence is directly linked to poor clinical outcomes, such as increased hospitalizations, disease progression, and health complications. We touched on it earlier, but up to 125,000 deaths annually are attributed to non-adherence in the United States. Patients with chronic conditions who are non-adherent to their medications, they have a 45 to 50% higher hospitalization rate compared to their adherent counterparts. And patients with complex chronic conditions, right, like your cancers, like your HIVs, non-adherence can significantly affect the treatment efficacy and lead to disease progression. So, and then financially, non-adherence to medications contributes to significant avoidable healthcare costs. Hospitalizations, hospital readmissions, due to non-adherence cost the US healthcare system $17 billion annually alone, right? With the high spend relative to their RX volume, adherence to these medications is essential to controlling overall healthcare expenditures. And then operationally, you have those barriers that can, non-adherence can contribute, right? You have your higher churn rates as patients may not refill their medications and they require more time and resources to manage as a result. Pharmacy can spend up to 30% more time managing patients with poor adherence compared to those that are adherent, right? And that comes in the form of, right, your increased follow-up calls, patient education, and additional logistical challenges. That time spent on those interventions reduces the time available for new patient acquisition or operational improvements that you can make to the pharmacy. And just to kind of wrapper it all together as to how it contributes into the overall healthcare ecosystem, right? It puts quite a strain on it, as you can imagine, and can contribute up to over 10% of the total healthcare spending annually, right? So big challenge and something that needs to be tackled. And that places pressure on everybody, right? Pressure on the payers, on the providers, and the pharmas themselves. And especially as the industry is starting to shift more to the value-based care models, patient adherence is a key metric for reimbursement. So low adherence rate directly impacts your payers and providers financially. So let's bring this to life through a patient story.
Yeah. It's important to think about how medication management across the continuum affects patients. And so we're going to talk about Maria. And Maria is a 32-year-old teacher, and she's in the midst of a Crohn's flare-up. And Crohn's, if you're not familiar with it, is part of the irritable bowel disease spectrum. But it's worse than that because it can be all the way from your mouth, all the way through your digestive system. And you think about the pain and the frustration and how a chronic illness really affects someone because they have to think about, where am I going to eat lunch? Who am I going to go with? Am I going to embarrass myself? So this is a really tough illness. She's been on a long history of steroids, has a flare-up, hospitalized, and the physician decides to change the regimen to Humira. Well, this is where the complications come in. Insurance, prior auths, labs, vaccinations, all the things that need to be completed. So how is that care managed? And this is where Inovalon's tools are really important. So with ambulatory surveillance, we're able to take all of that rich clinical information that we know about Maria and begin to put that into a clinical workflow where the pharmacist on the ambulatory side can weigh in and support that patient all the way through. And we're just coming out of Pharmacists Month in October, and if you think about the accessibility of your pharmacist, 90% of us in this room are, 5 miles away from a CVS or Walgreens or some type of pharmacy. So we're very accessible and we're trusted. And so these tools are so very helpful to take those workflows and create something that is incredibly impactful for Maria. And as the pharmacist is going through the treatment plan and using ScriptMed to fill this specialty medication, they realize that Humira is not covered by her insurance. So what's happening? We're delaying therapy even further. Skyrizi is suggested because that is part of her insurance, but also it's an easier regimen for her, every 8 weeks versus every 2 weeks. So taking all of that information in and what works best for Maria and her lifestyle. She wants to keep her career. She wants to be active. And so we have to think about the best way to support patients through their process. So our technologies are monitoring the patient all the way through, assuring, Maria, do you need your pneumococcal or your shingles vaccination for those that have chronic illnesses? Would you like to have that done in the pharmacy? There are lots of really amazing things that we can do to protect her well-being in the long term when we have the right information at the right time. Well, at regular check-ins, she's running a little behind on her refills, right? So questions can be asked. And what do we figure out? She has some depression. Of course she does. She's living with a really tough chronic illness. And having those conversations with the provider and then allowing the pharmacy team to watch medications for drug interactions and also just monitoring any adverse events, putting that into the system so that you can watch it over time so that her adherence is better because she's tolerating the medication. So I think technology is such a lovely place for us to be able to siphon through all that complicated data and allow the right information at the right time at the point of care.
And for predictive AI to really effectively manage medication adherence, we have to pull insights from multiple data sources, right? We have to apply the advanced analytics and then integrate it seamlessly into clinical workflows, right? We can't just analyze one type of data. We have to combine diverse data streams to really get that 360-degree view of the patient's journey, right? So that could be your member-reported data, patient-reported adherence and behavioral patterns, or your claims data, right? Your fill history, out-of-pocket costs, your prior authorizations, maybe it's your encounter data, provider interactions, clinical visits, and your notes from your EHRs. Could just be imaging and lab results, diagnostics that can impact those therapy adjustments, right? So we build in those kind of data layers, right? And then it's applying that advanced analytics on top of that. So we're gonna aggregate all of the data, then we're gonna filter it, normalize it, and apply analytics to really transform it into actionable insights. And I think that's really the key here, is turning it into action and getting it there at the point of care for these care teams that are really dealing with these patients.
Absolutely. And I always like to talk about the complexity of the medication use system, because from the very beginning of planning and selection of medications, right, Maria is at the center of how we're thinking about this. What is her lifestyle? What is her age? What's going to be most appropriate for her? What can she afford? So you're thinking about this full life cycle of selection and procurement, the ordering and transcribing, reviewing, monitoring all the way through. And you can see how easy it would be. We talk a lot in safety about the Swiss cheese model and how it's easy for just a few events to line up for that perfect circle to go through where harm can happen. And I think re-engineering this system with patient safety in mind and medication safety, like each step of the way, all of the things that can be done to improve with automation, with data, with conversations, and really understanding the patient, I think is super important. And as we go to the next slide, this is one of my favorite slides. I'm a big fan of the Institute for Safe Medication Practices. So ISMP put this out many years ago, and it's basically the error reduction strategy. So how do you think about preventing harm? And a lot of times, especially when I was a health system leader, if an error happened or something went awry, you would ask the nurse or the unit leader, what do we do? Harm has happened. How do we change our behavior? We'll educate. We'll put in a new policy. Well, that is the least effective way to move change in healthcare, right? We all take in so much education that doesn't really move change. So as you move up the error reduction strategy, it's harder to implement, but it's way more effective. And that's where the technologies come in. So fail-safes. Don't have certain medications on your formulary if it's not necessary. Then you can't pull the wrong thing off of the shelf. So there are ways that you can really think about all the way up this continuum of how do I get to that true forcing function where either the drug is not available because it's not needed in our pharmacy, or you have tools that can pause or stop you when you're headed in the wrong direction. So I think all of these, when I was in clinical practice, and I always had a slew of students and residents with me, this was something I would use with them often as a checklist. So each process that they were working through, I would have them think through each of these layers to come up with a plan. If I'm implementing a new process or I'm thinking about a current process, help us go through the full spectrum. So it's a really interesting way to think about harm reduction.
And so let's talk about how we get into risk classification, right? So when Maria gets entered into ScriptMed within the pharmacy system, she's created as a single record, right? But that record can then be referenced against the whole larger data set that we have available here at Inovalon, right? What that really allows us to do is classify her and see from the larger scale other patients like Maria, right? And that allows us to really predict what we would think her adherence rate could be, right? And just for sake of example, we classify into 95 to 100%, 85 to 95%, or a less than 85%, which means more than likely they may be non-adherent, right? So we are able to do that type of prediction and kind of know off the bat, just based on experience with previous patients, whether that's the same age, maybe it's the same disease state, or the exact same medication that Maria's been prescribed. We know what's happened in the past and how adherent people can be, right? So we're able to predict, and then what we're able to do is target specific enrolled programs for Maria, right? We can, say there's common side effects, for example, right, with this medication, and we've seen there's been a lot of adverse events reported from previous patients. I think we're able to then take that information and really create a targeted plan of care for Maria and say, we expect this may happen, right? We're gonna kind of create this intervention to the side here. Maybe when we're talking about your next refill, we're checking in and we're making sure we're touching all those bases just to see if we're getting some of those maybe early signs of a disease progression or regression, right? So we're able to enroll, and then it's really being able to deliver on that care. And I really like this graphic because it's a continuous loop, right? It doesn't just happen once and you kind of set it and forget it. It's constantly learning, getting better at predicting, targeting, enrolling, and then delivering, right? So really like this one. And as we talk about more of a case study here on the predictive model that we have at Inovalon, from our Moore Squared registry, we had the top 150 most widely dispensed NDCs in Inovalon's ScriptMed database, right? The study was over a 2-year period for a 365-day observation for each of the medications. We had over 1 million unique fills from 130 different numerical categorical features, right? And what we were really trying to predict there is precision and recall to give us what's called an F-score as it relates to the predictive model. And one of the things that we saw from this, that you can see from the chart on the left, is there's a few key things, right, that really can contribute to adherence. Drug price kind of being the top one there, right? If it's a really expensive drug, maybe I'm just afraid, right? I'm gonna mess it up, or my uncle has Crohn's disease and takes Humira. He accidentally, when he got the drug the one time, shot it, and it just shot across the room instead of into him, right? So he had to get another one ordered. Became a whole thing. But price definitely significantly can contribute to that. We also see package size and the route of administration. So as the package size increases, as we have a larger quantity, we're probably at a higher risk there for adherence. So these are the types of results that we were able to see out of this study using our Moore Squared registry and our overall data set here. And then how do we use it, right? So I have a couple screenshots from our ScriptMed application. When we talk about Maria as a data point, we see plotted here, there's other data points that are on there for the PDC score average, right? Proportion of days covered. That's really the key metric that we use to measure adherence, right? How adherent do we think a patient's gonna be? So when that therapy is created within ScriptMed, we're able to plot it and again, predict and see how does this patient measure up to previous patients that we have here versus one GPI versus another, right? And we can see it all within their therapy chart. It's all going to get stored, and again, right there, placing it at the point of care is again the real key with this, making sure that you have all the information at the right time. And then just more of those strategies that can be applied to address some of those adherence challenges, talking about packaging, right? Using, instead of like punch cards, we use some of those smart labels sometimes, or those smart pill bottles that can really help to track that a little bit easier. I think of my grandmother who's in assisted care facility, right? We have one of those machines that really, I think, has taken her care a step further to, there's no thought that has to be placed into it, right? It's just on a schedule, it's gonna dispense that medication for her and she has it. So really being able to use some of those technologies that we have here in this day and age, I think can really take it a step further here.
All right. Clinicians, when surveyed, and this was a HIM survey about a year ago, said that they look at roughly 18 different digital tools to find all the information that they need to make decisions about patients. That is absurd. And we wonder why there's so much harm and so many errors in healthcare. And I want to tell you about a paper that Liz Wiggins, one of my former colleagues, and I wrote with several others, because I can tell you all these cool things that technology can do, but is it really doing it? And this publication argues that yes, it does. And so implementing clinical surveillance in a large healthcare system, this was a publication about this implementation. It was around 200 hospitals. And we were able to do really amazing things that I was very skeptical that technology could actually accomplish. And one of the things, we were trying to get it funded, and I was meeting with the CFO, and I was showing him all the data, and he said, what's really striking to me he said this data doubled the interventions or the clinical interventions of a pharmacy team where pharmacists are highly paid individuals in your organization. And he's like, that's all you had to tell me, that data point. Because, endless productivity of staff is something that you don't have. And so streamlining the workflow with the productivity, that was a really important measure for him. What I cared more about was the clinical side of what are we really doing for patients with this kind of technology. And what was important to me was to assure that our patients had 24/7 clinical coverage, not when the clinical pharmacist went home at 5 o'clock, not when you're short-staffed and unlucky enough to be admitted to the hospital over the weekend, right? Everyone deserved the same care. So we were able to use a centralized model of pharmacists that were covering these rules and alerts for multiple hospitals, kind of like a hub and spoke. So there's lots of ways you can use this technology to protect individuals, but the time to intervention. So we had what were called high priority interventions. So think about MRSA in your blood, right? A multi-drug resistant organism and no antibiotic on board, or the wrong one. Those types of interventions of getting that, pushing it, right? The EHR will result your micro, but it's not always smart enough to say, this doesn't match your antibiogram and we're going to push it to the clinician so in real time they can respond. And with that particular intervention, we were able to go from 8 hours of getting the right antibiotic on board to less than 2 hours. And if you think about MRSA in your blood, you're going to lead to sepsis or death pretty quickly because it is life-threatening. So it was those types of interventions really made me a believer in this type of software, but also the return on investment. So we found about a 1 to 7 return on investment, and that was just hard dollar savings, drug savings, not the soft savings of reducing length of stay and those types of other metrics that you look at. And so by automating this, we also gave our teams real-time simulation because you don't have enough pharmacists or enough team members that have a specialty of pediatrics or behavioral health. Those tend to be areas where people are a little more concerned. Clinicians don't have a lot of confidence. So when you have this type of technology, you're in real time simulating and training, because when the rules fire, it's super transparent, it's rules-based AI, you can see why the rule fired, and we would actually put education into the alert, so if they wanted to know, they could go to certain literature articles and learn more about it. So there's lots of interesting ways that you can use this type of technology, but assuring that the care was equitable across the board was super important to me. And in the next slide, we'll talk about how does it work with the data. So basically, this type of technology, it's taken all that rich electronic health record data, really any data that a customer can send us, we'll take it. HL7, API, FHIR, whatever you can send us, because the more data we have, the smarter the tool is. And even with unstructured data, that's where we are right now, looking at the unstructured data. How do we structure that so it's a discrete field and that can go into the rules engines to make it even smarter? So natural language processing, we have a couple models coming around adverse drug events, around diseases. So you can see the disease states in the notes oftentimes, but it's not mapped where you can use it. We can't wait for ICD-10s to be mapped to understand everything going on with the patient. And then also oncologic markers and rare diseases. So you can pull that into the rules, which is really cool. And then it runs through this really slick algorithm of thousands of rules that we have vetted over the last 20 years and still vet and clean up every single day to have somewhere around a 70% hit rate of actionability. And if you think about clinical decision support in the EHR, that runs around 20% actionability is what David Bates and others tell us from the literature. So really cool systems. And this is, rules-based AI has been occurring for a very long time, right? We've been doing it for over 20 years. Now think about these other layers of AI that we're beginning to put into these tools of summarization, risk stratification, prioritization of patients. The opportunities are really endless of how we can continue to improve. And the next slide will show you just a screenshot of what does the workflow look like how is it streamlined. And it's pretty cool from a patient list perspective. And we put in little icons of hearts or something to try to give a visual of here's a snapshot of your patient. Here's everything that we can tell you in one snapshot of here are the disease states, labs or micros that are out of range are in different colors, and you can scroll over and it'll show you your lab ranges. So trying to put everything right at the fingertips so you can take care of people in a much different way and a much easier way to reduce the burnout. You probably heard Adam Kanzler say this morning in his presentation that for pharmacists in particular, 42%, I think he said, of pharmacists over the next 2 years are looking to exit our profession. And that's really terrifying to me because we're the most accessible. And so we've got to make it easier for people to do the right thing and our clinicians. And so the next slide, I talk a little bit here about medication reconciliation. And I was presenting earlier with one of the leaders from the Leapfrog group, and they're continuing to see medication reconciliation as one of the most troublesome of all processes. And I spent some time with my colleagues when I was in system leadership of how do we do this and how do we do it well? It is the bane of our existence. Nursing really despises it because it takes so much time and effort. And so we implemented a program with pharmacy technicians in the emergency department that would collect the home med list, and they would use like SureScripts data, pull it in, but it was the confirming, how are you taking this medication? Are you actually taking this medication? And that way the prescribers had a very accurate picture of what was really going on, right? Because if your blood pressure is high and that's why you're being admitted, and I tell you I'm taking my meds exactly as prescribed, I'm gonna add something else on. And that's not what's going on. Maybe they forgot to get it filled. Maybe, they take it once a day instead of twice a day. So I think it's really important with medication reconciliation in particular to have, you need the human side of it, and then technology can expedite it. But what really burdens nursing is they're kind of run into all these disparate places to try to get that information on the front end. And so this had pharmacist oversight on the front end, and then it made it super easy on the back end on discharge because you've got it right on the front end, and then you can go back and compare that for your med rec on the back end. And we had some really great outcomes in this, and mostly looking at the complications of patients and around a 12% reduction in those coded complications around adverse drug events. And the satisfaction for nursing, pharmacy, physicians, off the charts. They were thrilled. And it just takes a little bit of effort and time. What we found was nursing was willing to offset some of their employees to give the funding to do this because they were spending 30 minutes just on the medication list and med rec on the front end. And so we'll finish up this section here on monitoring. And I think, if we go back to Maria and we think about her navigation and then how you want to look at your whole system of where are gaps, what can we do better, really rich data and information that's bubbling up the signals in your system is very important. And as a clinician, I can say this, I don't think clinicians are always great at looking at data, understanding what they need, but we have way more data than what we do believe. So starting with what you have and finding those signals that say we need to put some effort, time, resources into fixing this problem. I often found myself in data paralysis. It was just so much information, but I think bringing it back down. I love Don Berwick. He was the president of the Institute for Healthcare Improvement, and we would go to these, his trade show every year, and he would begin by saying, what can you do by Tuesday? Because most trade shows end around Tuesday. And he's like, what can you do by Tuesday? Like, what is the thing that you can pick up? And I urge you to think about, this day and a half with us at Inovalon. What can you do by Tuesday as you're leaving and getting on that flight? What are you thinking about that's most important to you? And if there's something that we can help you solve, we want to do that, because you know the problems that you're experiencing. We know data, we know technology, and we want to help you through that. So find us. We definitely want to help. And so, Ben, I guess I would ask you as we begin to wrap up the session, for the future of medication adherence, how do you see data and technology continuing to improve for someone like Maria?
Yeah, I think, as we are able to continue to refine these models and even add new ones on top of it, right? I think we're only going to get better, right? And I think that's really positive, right? I hope everyone can kind of leave here with a positive thinking like that. I think, again, the more that we're able to sift through kind of the noise and really get what's pertinent and meaningful to these care teams and have it right there in front of them when they're interacting with the patients, I think that's what really makes the difference.
Yeah, absolutely.
Yeah.
Do we have questions from the audience? Or insights that you might like to share? If there's something that you're doing that's really important, would love to hear from you. They're going to bring a mic up.
They're going to come around
in
with
the back.
I think this gentleman in the front here.
Yeah, it's impressive. This is my first time at Inovalon. We use them for eligibility, and we also get preventive medicine from it. You're talking about medication reconciliation. I understand the headache about it, because the only way we're successful and why we're so successful is because we go into the home. And when we go into the home, there we see that the cupboard isn't the only place where there's medications. They're in the bathroom, they're in the refrigerator, they're in a million different places. If you don't have them all, when you see the patient, they're going to tell you yes, yes, no, no, and just to get on with it. But the real picture, and we actually take pictures of the medications while we're in the home so that we can even look back and say, was there a different prescriber on hypertension? Do we see that there's multiple hypertension medications? Definitely. Does Inovalon, to the question, is Inovalon have that module now that it works, and because I'm thinking, I'm seeing that, as I go to all these different sessions, I see that there's more and more that Inovalon does, more like an electronic medical record system.
Mm-hmm.
Is it already an electronic medical records product that you can access? Because if it would ingest all the medications and we had it right, and you had contraindications in there and it was clearly indicated, that would be insightful. But more so what you could do with artificial intelligence and prescribing and telling us, hey, listen, this is not working. The payer data is going to be incredibly valuable for you in order to be able to know if things are really happening or not, besides that initial good deal of information that we give you from the patient itself.
Yeah, thank you for teeing that up. I can start, and Ben, please jump in. So funny you ask. We have an ambulatory surveillance product that we're launching now. It is on the market. We are pre-selling it in January. It'll go to market, but we have customers that are using it today. And it does that very thing. And with the data stream data, like the power of Inovalon, of the More Square database, and pulling in all this rich information, we're able to look at the home meds and completion for as much as you can, right? And then if you're in the home and you're comparing it to that, we're pulling the information in for you to make it as fast as possible, but also as much data. And I'd have to know more about your system, of the type of information that you have, because the more data you have, then the richer we can make the workflow and the rules engine to run against it. But we can use claims data also. We can use the clinical data. And when you combine the two of those, it's really a rich way to think about the workflow. So then you can look at vaccinations and preventative medicine, and then the current medication regimen of issues, disease state, drug issues. So there are lots of things that this new module can do. And home care is one of the places, and I don't think my marketing colleague is in here that keeps saying, we got to be in home care, like that's where it's at. Mm-hmm. Right, that is fantastic. Let's talk more. Other questions or anything you want to add to that, Ben?
No, I think really well said. You know, on the pharmacy side, we do also have these products readily available today. You know, we serve, you know, primarily, I would say, a specialty marketplace, but we do also have infusion offerings as well that are ready to go. So, yeah.
Awesome. Other questions? All right.
All right. I think we can end it there. Thank everybody so much. Really appreciate the time.
Thank you.